everyone. A pleasant good evening, everyone. My name is Jovan Wilson, and I am a mass media specialist out of beautiful Guyana. I am so delighted to be here to be a part of a discussion that I believe is a pertinent one and much needed one as we discuss the topic of navigating women's health right here in the Caribbean. Now, as women, not just in the Caribbean region, but also all across the world, we generally have a tendency to neglect this particular element of our life, which is our health. And so with tonight's discussion, what we are aiming to do is trying to shift that paradigm and ensure that as women, we are prioritizing our health. Now, this much needed conversation is being hosted by WINBVI, which stands for Women in Need, British Virgin Islands. And this is an organization that caters to the empowerment of women. Now, they speak to this particular issue in many regards, but tonight they are providing an avenue for us to have this conversation, which is another opportunity for us to reach more women when it comes to the health issues that we are plagued with. Now, through advocacy, through education, through awareness, WIN addresses these needs. And tonight we'll be diving into the topics of polycystic ovarian syndrome, a very prevalent issue in our Caribbean community and across the globe, cervical cancer, and also insulin resistance and how we go about navigating some of these challenges. So on behalf of the director and founder of the WINBVI organization, the beautiful Miss Alicia Green, I would love to welcome you warmly to this conversation. We are streaming live out of the British Virgin Islands, Guyana, and other parts of the region. And so with that being said, it gives me great pleasure to introduce to you my delightful panel. Now we'll begin with the WINBVI umbrella. Tonight we are hosting Loyalty. Both of these queens are ambassadors of empowerment and champions of change. Beginning with Dr. Arliene T. Penn. She is a cervical cancer Thrivor, Mrs. BVI 2022-2023, and VIcon. Good evening, Dr. Penn.
Hi, good evening to everyone. It is just a privilege to be here this evening with my queen, sister, to talk about women's issues. Now, I just wanted to first start by saying that I'm a cervical cancer Thrivor. And I said thriving because I'm not just surviving, I'm actually working. I'm doing things behind the scenes to make. Yes?
I love it. I love the word Thrivor. I was actually going to ask you the meaning of that, but you beat me to the punch. Go ahead.
Yes, in terms of Thrivor, in that I'm not just living and just surviving. I'm actually working behind the scenes, working, of course, with a number of persons, a number of women, a number of persons in the community across the region as well, just to make sure that we are really paying attention to cervical cancer. You know, I wasn't paying attention to it because I thought it was just me alone. So for 17 years, I remained very much quiet about cervical cancer. And I remember one day as I was scrolling through the internet, and I came across some statistics from the World Health Organization that cervical cancer is the fourth most leading cancer death in women. And then when I saw the number 600,000, I think it was 660,000 women who were diagnosed. And then 350,000 of those women passed. And I'm sitting on the bed and I'm asking myself the question, I'm alive. It means, therefore, that it is my responsibility to go out there to do something, because if God has saved me, then it's my responsibility to go out and to talk and to help others. So I've been on this road, this race, because when you look at the information from the World Health Organization, it says that by 2030, we want to make sure that we lower the numbers, because we don't want cervical cancer to become a public health problem. What we want to do is to make sure that we are playing our part, men, women, clinics, doctors, families, just working together to make sure that we are lowering the numbers. Looking at the numbers in the Caribbean too, I was also concerned because we're talking about what, 30,000 women, 28,000. That's a lot of women, too many women. And my concern is this, Jovan. When you sit down and you think about how many deaths there are, my concern is in the future we may not have women around because we may not be able to procreate because obviously we would have lost our opportunity to do so because of the cervical cancer, or children will be raised without mothers. And I say that because I could have been in that situation. So I don't want women to go through a lot of the things that I would have gone through. So that's why I'm doing what I'm doing. I want women to know, fix, live, and to win. All right, Jovan?
I'm sorry, I thought we were having some technical difficulties there. Were you guys hearing me?
No. Not the response, but I'm sure you will respond to me now.
Yes, there's so many very important things you mentioned there. You mentioned being a Thrivor for so many years, which automatically means that you would have detected this in your early 20s. And that is a commonality we're seeing these days, particularly with cervical cancer, and something very alarming to persons like myself. What I've recognized over the past year is that women are not only being diagnosed at an early age with early onset cancer, obviously, but also some of them are dying from cancer. So this is a very important conversation. Very happy we're having it. And Dr. Penn, so much for the work that you've been doing so far. We're going to dive a bit deeper into it a little bit later on. But for now, I would love to head on over to the other queen on your court, which is our reigning Mrs. VIcon Curvé 2024. She's also a polycystic ovarian syndrome awareness champion, Miss Armoy James. Thank you so much for joining us.
Armoy James-Ibechem.
So actually, I'm Armoy James-Ibechem.
Thank you. Sorry about that.
No problem. So yes, I am the reigning Mrs. British Virgin Islands Curvé, and PCOS, or polycystic ovarian syndrome, is my platform. Not only because I was diagnosed, but mainly because it's my life's journey. And I was diagnosed when I was a teenager in high school. And at the time, it was very scary, but I was a teenager. And so my doctors told me at the time, you have nothing to worry about until you're ready to have children. Now, as a second farmer, children is the last thing on my mind. So I was just like, okay, move on with my life and I'll just carry on until it's time. No, I'm married and my husband and I, we want to have children. And there's this thing. It's not ultimately going to stop us from having children, but it is going to make life just a little bit more difficult for us to get there. And it took me a while to realize that polycystic ovarian syndrome is something that you should look at early, just because it is treatable. It is one of the most common causes of infertility in women. And as Black Caribbean women, it's more prevalent in our community. And so when I realized that I should have probably looked at it earlier or tried some different treatment options, then, it cannot, I won't say became too late, but we're now at this stage. So when I was tasked with finding a platform, I took inspiration from my lovely sister queen, Dr. Arliene Penn, and I saw that she was able to share her journey and be so vulnerable. I almost used to stalk her page, and it's kind of sad, but I was a stalker just because I just always wanted to hear what she had to say and how she overcome and, how she became the Thrivor that she is today. And I said to myself, you know what, Armoy, it's your turn to share your journey. It's not the same but it's a journey that somebody else out there can relate to. And when I started my journey, I was very afraid because I'm opening up my new home. My husband and I are not married a year yet. So it is a very new home, and I'm opening it up to the world, not just our community, but the world. He is of a different culture, and so that's another thing that we have to worry about. In their culture, you don't really talk about what's going on in your house. You kind of keep it to yourself. So I had to be very careful, but he's a very supportive man, and he said to me, go for it and push for it, because somebody else needs to hear what you have to say. And so now I'm here on this journey, and I can say that it's been tough, but I appreciate it, and I like what I do because I can already see the impact that I'm having in my community.
Well, I believe it requires great courage, great to be able to share in such a personal issue. And
Yes.
like you said, this is such a prevalent one in the Caribbean, polycystic ovarian syndrome. I mean, so often I'm in a group of 4 or 5 women, and at least one person has been suffering or has suffered from polycystic ovarian syndrome. And I know the doctors are going to be able to touch on this briefly. I want to move on to our next panelist. Thank you so much, Armoy. Next with us and out of my beautiful country, Guyana, is Dr. Oneka Scott. She is our maternal and child health officer attached to the Ministry of Health right here in Guyana. And she's going to be talking about insulin resistance, and the relationship that has to weight gain, another prevalent one in the Caribbean, but also add into the conversation of cervical cancer, because she's also one of the key faces behind our HPV vaccination campaign, a key way that we could actually prevent certain cancers. Mm-hmm. All right, so Dr. Scott, I will give the floor to you. Thank you so much for joining us.
Thank you, Jovan. Thank you for having me lend my voice to the campaign. I have to tell you that all of the topics chosen tonight have been having increased airtime, and rightly so. These topics have been extremely high on our women's health agenda. And one of the prospects of hope that we have for all of the 3 topics that we will cover is that there's a chance to manage, to prevent, and in the case of PCOS, thrive. And we're happy to lend our voices of advocacy to all that will be discussed in the evening session.
All right, and I know you guys may have thought it is an all-women's panel, but no, guys, we have some testosterone to balance things out, bring some nice balance to the conversation tonight. I am so pleased to be welcoming as our final panelists a very important man, no other than Dr. Nosa-Everest, and he's an obstetrician and gynecologist at the Diamond-Everest complex. Now, Dr. Nosa, I don't want you to feel overwhelmed by us. We're only here to compliment. But we are so thrilled to have you join the panel and, of course, offer your expert advice. Please give welcoming remarks.
Thank you very much for having me here. The topic that we're talking about is what I see every day. That's what I live every day. Cervical cancer, polycystic ovarian syndrome, which is related to insulin-resistant diabetic mellitus. So it's what like I tell you, that's what I see every day. It is a daily occurrence and appearances that I see all the time, and I have to virtually live with the women with this syndrome because and these medical conditions, because that's what I have to treat almost on a regular basis for more than almost 3 decades now of my practice.
Wow.
Yeah.
All right, thank you so much. All right, so let's begin with cervical cancer. Dr. Penn, like you mentioned, not only are you a fervent advocate on this particular issue, but a thriver as well. You mentioned thriving because not only are you surviving, but you're thriving. You're above the tides. You're paying it forward with your advocacy. You have been doing this for a very long time. I think you are a 20-year thriver, correct?
Yes, I am.
Evidently, Dr. Penn and so many of us, we are encouraged as young women to go out and get our pap smears done, which is essentially one of the key ways of detecting cervical cancer in its early stages. But certainly it's a thing that we neglect to do. What do you think is the stigma attached to the process? And what got you particularly to the doctor to be able to detect this disease?
I don't think I heard the second part, but I'll answer the first part first. In terms of, let us go with the question again because I can't really hear clearly.
Oh, I'm sorry. I was asking, why do you think there is such a stigma attached to getting tested for cervical cancer?
Okay. Well, first of all, when you're growing up in society, we have different names that we call the vagina.
Yeah.
We call it fanny, a whole set of other names that are not even the real name. And sometimes in a lot of communities, you are taught that that's one of the most important parts of your body. So when something is wrong with it, it means that something is wrong with you. So because of these things, sometimes people don't want to come out and say anything about it because they are ashamed. And I'm sure that Kathy from JTV would tell you that there was a time when I used to call, when I came out first to speak, I used to say, that thing and then I got the courage to say vagina because that's really what it is. And then sometimes you have to think about the cultural aspect of things. And then sometimes you have to think about persons we just don't want to walk in the streets with your head down in shame. And then there's this word called barren, because you can't have a child, something is wrong with you. But there are other options, there are other options. So for me, I got tested because of a free pap smear screening. And it had nothing to do with cervical cancer. It was just screening, cervical screening. And it is through that's when I learned that I'm going through a process where I'm hearing words I've never heard of, squamous cells. I don't even know squamous cells, dysplasia. So I'm hearing all these names, and I am, as a young person, have no idea what these words are. And I felt shame at the time in my early 20s because something is wrong with that part of my body. Now, what I do now with women is what I wish that I had done with myself or someone had done with me in my time. So I work with women so that they feel confident first about who they are. You feel confident about your body. So because you feel confident about you will get up and you will go out to get tested. When I started the campaign first, I would have raised some funds to do a soiree to raise monies to help the women pay for the pap smears. And it was only about 100 and something women who would have participated. And then I realized that, okay, Arliene, you're going to have to change the strategy just a bit. So it was know now, fix early, live life beautifully, fearfully, wonderfully. And then I realized I had to take off all those words and just know, fix, live, win. If you know what's happening to you now, then you can go and fix what is happening to you so that you can live and enjoy life. And then win means that you would pay it forward. But in the middle of all of that would be just loving yourself. So I had to teach and talk to women a lot about loving themselves. How did I do that? I entered the song competition and I sang Reclaiming Me and I sang Self-Love, so that the words now can penetrate the hearts of the women so that the mindset would change. Now, I can say that more women, since I changed the campaign strategy, we had about 300 and something women who would have signed up just this year to get their pap smears done in February. So what I usually would do, January, that's cervical cancer awareness month. We talk about cervical cancer, we talk about the HPV, and then sometimes there's discussions about the different layers, a hysterectomy. And then when February comes, that's when the doctor visits are scheduled, because that's the love month. And that's why I'm talking about love yourself, because if you love yourself, you will go and get yourself tested. And if it means that I walk with the women, because sometimes I've been able to be present with the women as well, because some women are afraid as well of what is the name of that? That's
Speculum.
yes, because that's uncomfortable, right?
Yeah,
It is.
It's very uncomfortable. So because it's
They
uncomfortable,
have plastic ones.
I know they're plastic. They're plastic and they're iron ones. So because there's a plastic and iron ones, you have to sort of talk to women and talk them into the importance of making sure they get themselves tested so that they can live fruitful and productive lives. Because look at me, I'm living still, because early detection, it saved lives. So I want them to know, fix, live, and win.
Thank you so much, Dr. Penn. And like yourself, there's so many persons who are dreading the process. I don't know one woman that I could call on that says that a cervical cancer pap smear, or getting a pap smear in general, is a pleasant process. Yes, there's a way to make the process a bit more comfortable, but generally it's one that scares us. So I'm very happy that, and I think also based on your campaign and also on your approach, because approach is everything, Dr. Penn, you being able to show up, not just somebody who's advocating for the particular issue or the challenges that surround cervical cancer, but also saying, hey, I've been there, I've done this, I am here with you. You have my support. I think that's such a critical part of the entire process. This now allows me to segue to Dr. Scott, because we know that besides British Virgin Islands and Guyana, where we're hosting this out of, across the region, it's such a major concern. And I know that you are one of the key persons behind the HPV vaccination campaign here in Guyana. There's a very aggressive campaign to ensure that more persons are vaccinated to prevent cancer. So can you tell us why early detection is key, and also what's the role of the HPV vaccine? How does it work to prevent cancer?
I lost you there, Jovan, just a little bit, but I think I heard most of your question. Before we go into the WHO targets, I do want to stress on something that Dr. Penn mentioned earlier. One of the key barriers to health is education. And education comes in all different formats. It's important to tell the survivor story, and in this case, the Thrivor story. I really like that. Um, but it's important to reach home to that family. And note, I'm not saying woman. In the case of cervical cancer, we have to look at real families, because everyone is influenced when that female figure is affected. So it's important to reach families with the message of prevention and early detection. Our WHO targets look at 90. And in this case, the first 90, which speaks to prevention with the HPV vaccine, is simple, it's key, it's inexpensive. And inexpensive is important in the public health sphere because finance is a determinant of health. Finance is a determinant of access to health care. And in some of our lesser developed countries, and in the case of the Caribbean islands, we may not have all the resources to treat. We may not have all the resources to early detect. And so prevention is key. It's amazing to see the gains that the HPV vaccine in the last 15 years are making in countries that are more developed, countries like Australia, Places like the UK, countries in the US where they pay hundreds of US dollars for the vaccine, but undoubtedly the incidence of cervical cancer and cervical dysplasia has been reduced to a 90% of cases. And that's remarkable. That's a vaccine that treats or rather prevents against cancer. Name me something more spellbinding. Name me something more achieving, a badge of honor for public health, you may call it. That's a vaccine that truly saves lives. Because, as you mentioned earlier, Giovanna, this is very important. Vaginal health, unfortunately, is still taboo. So, if we don't prevent, it is possible that detection will be until a later stage or a more advanced stage of the carcinoma. So, primarily right now in the Latin American and Caribbean territories, with the exception of some Latin American countries, over 60% of cervical cancer is detected in stage 3 or 4. That's over 60%. That means just about 40% detected in stage 1. And you really want early detection to be able to have a thriver or a survivor. But with a vaccine given at 9 years old, which is the age recommended by the World Health Organization, we are not only able to prevent in our part of the world cervical cancer, but we're able to prevent genital warts, which, as a side conversation, is also another form of sexually transmitted pathology that has been taken a very important rise in the prevalence platform in public health. And with the advent of more education in schools targeting especially sexual and reproductive health, young people are coming forward with the broccoli or cauliflower lesions on their genitals, males and females, and in capturing that data because now they're more sensitive to seek health intervention. That is how we are able to identify that yes, there is a rise. HPV or human papillomavirus is very, very common. It's one of the, if not the most common sexually transmitted disease. But there's so many subtypes of the HPV virus that if I sit next to you and I rub you with my hand, I can possibly transfer one of the milder types of HPV to you. It's important to let the populace know this. It's important to distinguish between HIV and HPV. It's important to let people know that with the expanse of knowledge and the spread of knowledge, there's really nothing to be afraid of. Once
Yeah.
you understand that everybody is vulnerable, then you understand that everybody has that right to prevent. And parents have the right to prevent their children from being ill. And now, with the age extended to 45 years old from 2019, adults have that right to also prevent cervical cancer. Now, the good thing about HPV vaccination, and there have been countries who, and some of the countries in the Caribbean, like Trinidad, Caribbean associated Guyana, have also extended the age to 45, taken the example from other countries in the UK. So the good thing coming back about the vaccine is that even if you have been sexually active and previously exposed in your life to a few of the strains of HPV, there's still benefit in being vaccinated. Remarkable, absolutely remarkable. The seroprevalence of the vaccine, one of the really important pieces of good news that we've had coming out in 2024 about HPV vaccine, and this is the quadrivalent, just the four-valent strain that we access in our part of the world, is that with now one dose, we are able to protect our young people, especially those who have had no sexual exposures yet. And so before, because HPV is not a vaccine that is cheap in comparison to the other antigens, before we would have had to give 3 doses. And now with one dose, we can report coverage and at least that immunity that we wish to have against the HPV virus. Now, this is where after saying all those great things about HPV, this is where we come to the realization that there is a challenge. We have a good product. We have a
Yes.
product that has been proven to save lives, that has been proven to decrease the incidence of cervical cancer. But we have hesitancy. We have hesitancy in the most unfortunate of circumstances, and we have hesitancy simply because of ignorance, and that's the unfortunate circumstance I was referring to earlier. People do not know. In fact, the information getting to people in our part of the world is disinformation and misinformation spread by social media. It's interesting to note that the countries that such disinformation and misinformation emanated from are the countries that have very high HPV vaccination coverage. Those are the countries that initially in 2012, when there was all the speculation about the vaccine and a completely non scientific basis, and there was a bunch of misinformation and myths being spread. Those are the countries who had individuals and healthcare professionals and healthcare allies and advocates rise up to have their voices as loud as those voices that were spreading misinformation and disinformation. Now, that is a problem in our part of the world and in the Caribbean. Our voices are not as loud as the anti-vaxxers. And so you have that information still circulating, still thriving, still influencing people who are none the wiser. And so it's our job as advocates, as scientists, the word scientist, especially in the public health setting, in the mass media setting, um, in the setting of those persons who are related or not to the medical sciences, means that you have to seek truth. And when you seek that truth, you spread that truth. And that is our role in society, to understand the truth and make sure that we educate those persons who are vulnerable. Because here it is again, and I would reiterate, and this is something that I never stop saying, we have a vaccine that can prevent cancer.
All right. Thank you so much, Dr. Scott. Quite a mouthful. So much information there to digest, and very good for our audience as well. You mentioned that the vaccine is now available, and in some areas free. There's free access, and that is important because, like you mentioned, finance is a major deterrent to taking care of our health sometimes. Did I hear you correctly when you said that the HPV vaccines can be given to children as well from an early age?
Sure. So in Guyana, we have been campaigning for HPV vaccine for well over since 2017 when we reintroduced the vaccine. And so our target, our WHO age group was 9 to 13 initially. And like most countries, we added boys in 2019. And then we've increased our age group to 45 years old, 9 to 15 being eligible for one dose. And after then, we give a two dose and three dose series, depending on, of course, the risk exposure and the individual. Mostly those within the over 15 to about 18 gets two doses. But of course, one dose is the goal. We do want to, because when we start vaccinating a cohort, we look at catch up and then we look at our target group. So ideally, 9 years old is the best time to administer the vaccine. And this is what is done the world over.
Thank you so much. All right, so we have to segue because we have more topics to get into. I mean, we could really dive into this all night long. There's so much to sift through. But we want to segue now to Queen Armoy. I want you to tell us a little bit more about your personal experience, like you mentioned, and we really applaud your bravery and your vulnerability on this topic because this is a common one. And oftentimes, I can also share that I have had experiences with polycystic ovarian syndrome as well. Amal, we can agree that it's almost like a very lonely journey. A lot of the symptoms that you experience, the very extreme symptoms, sometimes it's even hard to explain to somebody else, like what is going on with you. So just, can you tell us a little bit about some of the challenges you've had and how you've been able to navigate some of those issues?
All right. So as I mentioned earlier, I was diagnosed when I was a teen in high school. Around my last semester or so of second form, going into third form. And at that time, I would I was told it's nothing to worry about until it's time to have children. But as I grew older and when I started university, my symptoms started to creep up more on me. And the first thing they do is place you on birth control because birth control regulates your period. But birth control does more than regulate your period. Well, for someone who has PCOS, it does more than that. And so it depends on the type of birth control you're on. You can get side effects. So for me, my journey on birth control was, for lack of better words, terrible. I gained a lot of water weight, and PCOS does come with its own set of weight gain because most women who have polycystic ovarian syndrome do suffer from insulin resistance, which then causes you to gain weight. And so I'm fresh in university, from the Caribbean, and I'm looking all good, but I have all of this extra water weight from birth control. And so for me, I was just like, yeah, no, I don't need this thing. And so I stopped it. Now, for persons with polycystic ovarian syndrome, we know that having a period is something that I don't want to say we miss, but sometimes we wish we got. So women get their periods every 28 days. They have a regular cycle, that's an average woman. But a woman with PCOS, polycystic ovarian syndrome, it's a little different for us. And so our periods, our cycle can go up until 36, sometimes 90 days. Sometimes we go a year without seeing our periods. And some people may rejoice because, you don't have to think about it. However, you get all of the symptoms of having a period. You get all of the mood swings of having a period. You feel terrible just like how you feel when you're having a period. The period just don't come. So it's like you're in this cycle of just being stuck. You get there and then you're waiting and then nothing happens. But you have to go through it all over again. And so for me, it was very, very, very lonely because people didn't understand why I missed having a period. And I was just like, because you get a release from your moods and you get a release from, everything that you're feeling. But for me, I don't, and I still have to go through it. And so I was just like, man, when I didn't see my period for a month, I was like, man, girl, this is not working. This is not good. And it comes with other symptoms as well. You have excess bodily hair, so you have an extra mustache, or there's just so many things about it. And there's this thing called a PCOS belly. So we call it a fupa in the modern world, but it's a PCOS belly. And then some people say, oh, you should just go lose weight, go to the gym and lose weight. I wish I could. It doesn't work like that for women with PCOS. Our bodies are different. And so we have to deal with things differently. So for me, when I started taking my journey a little bit more seriously, I visited the doctor to ensure that, there was nothing else that was wrong, because with PCOS comes underlying conditions, and one of the biggest ones is diabetes. And it's something that I am very afraid of. I don't ever want to be diagnosed with that. And so for me, I was just like, yeah, no, I need to ensure that PCOS is it, and that's it. Unfortunately, it wasn't. I was also diagnosed with what's it called? What is this? A dermoid cyst. And so it didn't necessarily affect my PCOS or cause it to do anything else, but it was an additional something that I had to deal with. And so I decided, that I would go ahead, have that removed so that I could continue on my journey to PCOS. And so I went through that whole thing of having surgery, and, it was very scary, very lonely again, because people didn't understand why, and I came out on the other side saying that, okay, this is a fresh start, or a new leaf for me to continue on my journey. And so one of the biggest ways that I have been tackling my PCOS is through lifestyle changes. So I did mention weight gain. Studies have shown in my research that I did, studies have shown that women who lose at least 5% of their body weight can see significant improvement in their symptoms. And so, their period will come back. They won't lose everything, but, it will be a little bit more manageable. And then they start ovulating, you can have babies. It's a more pleasant experience to live through. And so I started my journey. Now, it's easy to say, go to the gym, just get on the treadmill, do a lot of cardio. But what I realized is that women with PCOS have higher cortisol levels. And cortisol is a thing in your body that says fight, flight, or freeze. So for women with PCOS, we are at a constant state of fight or flight. So we are always anxious, we always have feelings, we always have something extra. And so doing a lot of cardio increases our cortisol levels, which then causes the cycle of PCOS to just start all over again.
Right.
So for me, it's important that we do slow weighted workouts to ensure we're building muscle while losing fat. We manage our cardio, we manage our calorie intake as well, and we just keep moving. The idea of PCOS is to keep moving, keep your body going so that it's better able to process your day-to-day. So that's how I cope with my PCOS. I'm trying my best to do as many lifestyle changes as I can so that I don't have to visit Dr. Nelson and get on pills over time.
All right, thank you so much, Armoy. One of the things you mentioned is almost like a lack of support in this area. I think one of the things we don't speak about enough is also how this affects the partner. I'm very happy that Dr. Scott mentioned that when we're dealing with a cervical cancer patient, we also need to deal with the family, because everybody are dealing with the side effects, directly or indirectly, of this particular issue. So how did you navigate that with your partner, and what do you want persons in relationships to know about how they can support their partners as well?
So to be really honest, we're being transparent here. And initially, when I met my now husband, I lied. And I lied because I was very afraid. There's a stigma similar to that of cervical cancer where barrenness is the thing that comes up, because PCOS is the leading cause for female infertility. And when women hear infertility, they hear, you're just damaged goods. And my husband is Nigerian, and he is very Nigerian. So for people who know him, know he's very Nigerian. And for me, we have all of these, we have different mindset for people with different cultures. And so for me, I was like, oh my gosh, how am I going to tell this man that I may not be able to give him children? I lied for as long as I could. And then we got engaged. So now at this point, I can't really lie anymore, because we're going to get married. And eventually they're going to say, Charles, what's happening? You guys are married a year, 2 years, no babies. And so I had to come clean eventually. And it took some conversation between us, because PCOS is not something, it is common, but it's not talked about. So a lot of women, or people I should say, don't know about it. And he's a man, so it's the last thing on his mind. So it took a lot of conversation to, get him to understand exactly what's going on. One way that I found was easier for him to understand was to bring him along with me to my doctor visits so he can ask questions, so he can know what's going on, And that's how we got started. So I do not recommend that women lie. Don't do it. Don't do it.
But Jovan, let me add to that because in my case, right, I met my husband when I was going through the process. I was just a newly cervical cancer survivor at the time, right? And in being the cancer survivor, what I did, I invited my husband to come with me on the trip when he decided that he wanted to marry me. And I said to him, because from the first time I met him, I said, listen, I can't have any children. So just so you know, and I'm a cancer survivor. So I took him on the trips with me so that he can see what I was going through, because I wanted to see whether or not if he would want to stay with me, knowing that I have to go through this process because when you become a cancer survivor, it is the doctor sees you every 3 months, every month, then every 3 months, then every 6 months, then every year. So for 10 years, we were going through this process. But when I realized that the first 3 months, 6 months, he's still there, we got married. we got married. Yeah. And then we were also talking about symptoms because I had to do the hysterectomy, but they kept my ovaries. So you can imagine for 20 years, Doc, for 20 years, I'm still feeling the symptoms. I'm still feeling the cramps, still feeling every single thing as I'm trying to live life as well. So right now I think I may be going into the other phase where
you have a personal support.
We don't have to keep planning all the time. But I'm alive. I'm alive to tell the story, to help others. And I'm so happy that you're alive as well and you're kicking in, you've gone through your experience.
Yeah, and I think support, and I keep saying support is probably one of the biggest
things.
Because, it can be very, very lonely. Trust me, like you feel like nobody understands. And having that support system is the most important thing. And I think it's one of the reasons why I wanted to start out my PCOS campaign as an advocate and as a support for women. Because yes, they can go to the doctor, yes, they can do all these things, but who do you call when the doctor has just read out all these things to you?
Doctor, who do you call?
And you have no idea what to do. The doctor said this, and you're watching him like,
what are these things?
Yeah. And you leave the doctor office and you feel so overwhelmed. Sometimes you feel defeated because, it always feels like bad news. And so I just wanted to be, I won't say wanted, I want to be. And I think I've already started to be that person that women can say, Armoy, this is what's happening now. I just need somebody to talk to, or what to do next, or like where to go next. And I'm very appreciative of the people that's around me, that's been supporting me through everything, because support is really what we need.
Indeed. Thank you so much. And we do have some questions coming in. We're a little pressed for time. But very quickly, Armoy, this question is for you. It reads, what advice would you give to young women who's diagnosed with PCOS? We have a few questions, so we're going to go through it very briefly. And then we want to talk to Dr. Nosa a little bit more.
Okay, so to answer that question, Mom, so my first advice would be to just take a breath. Take a breath first. Being diagnosed with PCOS is a lot because it's all the information at once. It's take a breath and then to always remember that you're not alone and that giving up is not an option. I've said in many interviews that I will have 4 children. 3 boys and
Amen.
1 girl.
Amen.
And when I have the girl, she'll be the last and the shop will be closed.
All right.
And I can say that now
Amen.
because I believe it, and giving up for me is not an option. And so I want women to remember that as bad as you think your PCOS is, giving up is never an option.
All right, thank you so much, ladies. I have to toss it over now to Dr. Nosa. Dr. Nosa, we have you here for a very special reason. We need your expert advice on polycystic ovarian syndrome. I mean, you can weigh in on the other topics as well, but this is a prevalent one. This is also an issue that doesn't yet have a cure. From your seat as doctor, how have you been able to help women navigate these challenges, and what treatments are being offered particularly to these women who are dealing with polycystic ovarian syndrome?
Yeah, thank you for the question. Like I tell you, this is what I see on a regular basis. Yeah, polycystic ovary, like you said, somebody have asked how early would people go and test for polycystic ovary. You don't really necessarily have to go and test for it. It's usually diagnosed from adolescence, as young as you just discover some features. When you start seeing your period, sometimes one of the commonest symptoms is skipping periods. So that's why they call it a syndrome. In the old time, they used to call it PCOD. We don't want to use the word disease as syndrome. Syndrome is a complex of many other things that goes with the polycystic ovarian situation. So it is sometimes absence of period, androgenism. Some kind of a big word. Let me say the male hormones are more expressed. That's what is androgenism. You get hirsutism, you get polycystic ovary, maybe on one ovary or on both ovaries. Then you're at risk of getting pregnant. You don't ovulate necessarily. Some ovulate, then some will get acne. So the treatment for polycystic ovary depends on what the person wants. When they come to us, the age, what they want, what is troubling them. So if the person is getting to have children, we try to test which type of symptoms is having. If it's not ovulating, we make them ovulate. We can induce the ovulation. If the person is worried about the excess hair, you treat those excess hair. If the person is worried about the acne, you treat the acne. So the treatment for polycystic ovary depends on what the person wants. And we don't want people to start thinking that you can't get pregnant or you can't have children with polycystic ovary. It just makes getting pregnant sometimes challenging. We've managed and delivered many women with polycystic ovary with many children. So depending on how or what you want and what treatment you want or what is your goal. Then in this aspect, I could just help a little bit. Dr. Scott and Dr. Penn have said so much about cervical cancer. Few things I just have to help add to what they have said. We have few ways of diagnosing cervical or preventing it. One of the things I could tell people is that for those who are very much afraid of the mystery surrounding vaccination, it's not only vaccination you can use in preventing cervical cancer. In short, it is one of the only gynecological cancers that we can prevent. There are so many gynecological cancers: ovarian, vaginal cancer, endometrial cancer. Cervical cancer is one of the few ones that you can prevent. And apart from the HPV, for those who want to take the vaccine, get HPV testing. You can test it through the cervical smear or through blood test. Or you preventing it again, you do cervical smear, this pap smear. These days we don't even want people to start doing it so early. It is recommended from the age of 25. And you don't have to continue to do it after you hit the age of 65. The reason why they say all these things, because of research have shown that you don't see it commonly when you are below 25 years old, and you don't see it commonly when you are above 65. But if you have an abnormal pap smear at the age of 64 or 65, you don't have to stop at 65 even when it's recommended to stop. Mm-hmm. Just make sure that you follow the treatment until you are free. Mm-hmm. That's why I said that even these days, sometimes people who are diagnosed very early, in the 20s, late 20s, early 30s, we do what we call fertility sparing surgeries. We could cut off the cervix. It's called tracheotomy. And leave the uterus. There are so many ways you can get pregnant without a cervix. So there's so many ways you can deliver without having to push the baby through the vagina. So most of the time we have various ways to make people get pregnant without having your cervix. So there are so many things that have come up during the course of medicine, medical journey that can help people with both polycystic ovary and cervical cancer. You just have to get close to your gynecologist.
Right.
So that people don't, the words you hear from the street or from your friends, the stigma attached to it, you can navigate those. And I'm sure Dr. Scott can complement what I've said in this aspect. But you guys have done a good work with talking about it before I came in here.
Thank you so much. Before you move on, Dr. Nosa, I want you to quickly touch on the role that diet and possibly even herbal remedies play in the managing of polycystic ovarian syndrome. Then we're going to segue into Dr. Scott.
Yeah, thank you. I mean, I'm not too much into the supplementary treatment and, other herbal medicines or complementary medicine. We were not trained in that direction. When it comes to diet, what we tell basically typical polycystic ovary women is that something you don't really have to be on medication. Lifestyle changes, diet, weight loss, and exercise. Those three things that you just make sure you maintain your weight. Like Armoy said it, if you lose 5 to 10% of your weight at any particular time when you have polycystic ovary, some of the symptoms will regulate themselves. Yeah. The period will come back normally. You will start ovulating if we're not ovulating before. So to tell you about particular food not to eat, we just want you to make sure that you manage your diet, manage your weight, and exercise regularly. About supplementary medicine, like I said, complementary treatments, we are not too vast in that direction. But what I tell my patients is that I don't discourage you from using those remedies once it works for you. Yeah, we just don't know, we can't prescribe it for you. If you know that it is helping you, you can go ahead, but we will give you what we know will help you in orthodox way.
All right, so we are really tight on time, but I want for us to dive into the other aspect of the conversation, which is one of the primary reasons we have our Dr. Scott here, and that is insulin resistance, which, by the way, links to polycystic ovarian syndrome as well, being one of the main types of polycystic ovarian syndrome. So Dr. Scott, what can you tell us about insulin resistance, how it lends to that particular disease, but also another very prevalent one, weight gain?
So, Jovan, you'll have to give us a little bit more time and another session. Listening to Armoy, I realized that for far too often and now we're doing it in the medical field, but we're not connecting the two initially. We should. As soon as we diagnose somebody with PCOS, we should check to see what level of insulin resistance they have, because more than likely they do. There are some schools of medicine that argues that PCOS is as a result of insulin resistance, and there's some schools that argue that they are compatible in the fact that one leads to another. But either way, you are very correct. They are very, very much related. One of the things that is very common to find with insulin resistance, and insulin is really that key hormone that we all need. It helps to push glucose into the cell, and glucose for us humans mean energy. We all need energy to survive. We all need glucose to survive. But too much insulin allows for that glucose to not only be excluded from the cell, not being entered into our cells, but it floats around in the bloodstream, and that's what makes us gain weight. It's what affects our ovulation cycle. And basically, if you don't have glucose enough to activate your mechanism of your follicle stimulating hormones or your LH hormones, you're infertile. And there again is your linkage to to PCOS. In a male, if you don't have glucose regulation with the male reproductive system, you're also infertile. So it's not only affecting women, but it's also affecting men. And so that insulin resistance is actually a condition, a metabolic condition that's more common than we really do know. More people are suffering from insulin resistance than they are aware. And by the time they are aware, because what our bodies try to do, that lovely organ we have in the abdomen called the pancreas, it makes more insulin. So if we needed to have probably our normal amount of glucose enters the cell with normal secretion of insulin when we were young. In order for that same amount of glucose to enter the cell, the pancreas compensates, makes more of the insulin and more, but less and less glucose is entering the cell until it really crashes, and then you enter into that pre-diabetic phase and then eventually diabetes. Again, glucose is very essential, but if we don't have glucose added to our diet, our body makes it. So we don't have to take in glucose in order to survive. And that's where now the world has recognized that a revolution needs to occur. And sometimes we don't understand how added sugars, which is really I have to say, the devil incarnate, but we don't recognize how the devil incarnate being added sugars are entering in our diet. Although we say eat legumes and reduce carbs, whenever we buy anything in a tin, even legumes in a tin, there are added sugars there. If we buy processed foods, there are added sugars there, and added sugars is really what is causing us harm because we don't need any of that. Carbs equally is another devil incarnate because that eventually gets converted into sugars. And for those with PCOS and with insulin resistance, lowering our carbs is essential to regulating our insulin levels and our glucose levels. Now, again, and I'm looking at our time, in order for us to really simplify and dissect how insulin resistance affects over 90% of the population today, we would have to go into basically how we live our lives. There's so many things that we have taken for granted, including the fact that we have work environments um, and lifestyles that we no longer ride bicycles. So we are a little bit sedentary in that effect. We take a car or vehicles from point A to point B. And go back 100 years or 200 years, we walked more. We had more physical exercise in our daily routine. So we were able to burn more calories. And burning calories is indeed one of the key factors to battling insulin resistance. But I want to go back to what Armoy said earlier. Depending on how we burn those calories too, has to be balanced because and this is where it gets complicated. We do not want the body to overcompensate in any way possible to produce more, and that brings me to another point, and I'm really trying to get everything in here, but that brings me to another point of artificial sugar. So we look at sucrose and we look at fructose, and we say they both have 4 grams each, and the food industry will argue, well, they're the same, but they're not. And so they say, okay, you're not getting the fructose, we're going to give you artificial sweeteners, but they do the same thing. What it does is that by the time that artificial sweetener touch our tongues, it sends a message to the brain, and the brain produces more insulin. And there you have a lot of insulin, so hyperinsulinemia, and that is floating around in the blood, and of course causes all that we are seeing today. So to wrap it up, we do need to be aware that once we don't have energy going into the cell and we have a lot of insulin there, we will feel tired. it will lead to weight gain, because essentially we're not taking the glucose anywhere. So it goes straight to the fat tissues. The fat tissues get released, picked up by the liver, and that cycle continues. And more fat tissues are produced. So it really we call in medicine called hypertrophy of the fat tissues, that really breaks it down to poor mental health, poor metabolic health, poor muscle health, poor organ health. And there you have it, insulin resistant.
Thank you so much, Dr. Scott. A recurring theme I'm hearing here tonight is diet plays an essential role in correcting some of the issues that we have and preventing some of the issues that we're discussing tonight. So that's definitely one of the recurring themes. We are definitely out of time. Like you mentioned, Dr. Scott, we have to come back. I mean, we are barely touching the surface. I'm having so much fun being informed on these issues. And I know a lot of women are tuning in with real questions, because these are real life issues that we don't normally discuss. So we definitely have to come back, ladies and gentlemen. Dr. Nosa, you're not going to be able to run from us. But very quickly before we wrap up, great topic tonight. But very quickly before we wrap up, can you just give our audience a closing statement on each of your topics and some advice possibly? And as you do that, please let our audience also know how they can keep up with you, whether you're on social media or there's contact information that you'd like to share. And then we can discuss afterwards when we're coming back.
So insulin resistance is that stage that we can avoid. It's very important to remember that, Jovan. It's the stage that can be reversed. It's the stage that can be improved by our lifestyle change, by our activity, by our diet, and sometimes we will need medications. If you have a family member that's diabetic, you probably run the risk of being insulin resistant. If you're diagnosed with any other metabolic syndrome like Cushing or PCOS, then you should be screened for insulin resistance. If you're stressed, you're gaining weight, you're able to identify why you're gaining weight, you should be screened for insulin resistance. And sometimes the tests are very simple. We advise our patients to measure our waist circumference, which is the maybe the bigger part of our tummy. We multiply that by 2. And if that is more than your height, then you're probably insulin resistant. There are the telltale skin signs that we can look for, maybe the darkening of the neck, the darkening of our armpits, we're tired, we're sluggish. And again, weight gain is important. But very noteworthy to mention is that this condition, which is now one of the most common conditions seen in primary health care, can be reversed. 1 in every 3 persons you know is probably living with insulin resistance at the moment and completely unaware. We start screening as young as in our 20s, and sometimes that is when we're also diagnosed with other metabolic symptoms. One of the things is very common too, if you're hypertensive or have a tendency of having high blood pressure in your late 30s or early 40s, you're probably also insulin resistant, and that's probably why you're having your blood pressure high. And we can discuss that on another platform, because there's so many things that are connected to our bodies having high levels of insulin. I am not found on social media. I don't have a platform, but I would definitely encourage our listeners out there to use all the medical platforms to educate yourselves. There are many of those sites, like the Mayo Clinic site, Medscape sites, even the World Health Organization sites that would offer information in layman terms, and of course platforms like this one that I'm sure will be returning to discuss the topic in a way that people can understand and identify and probably get themselves screened.
Thank you so much, Dr. Scott. You've been most informative tonight. We really appreciate your expert advice on the insulin resistance, as well as how you've been able to add to the overall conversation. I want to give Dr. Penn the opportunity to close out.
Okay, my message is always simple, Jovan. In anything that you do, you have to know now, fix early, so that you can live life and then you can win. So know, fix, live, win. So if you don't remember anything else, know, fix, live, win.
And Armoy?
So I just want to remind every woman out there that along this PCOS journey that we're not giving up. And it is PCOS Awareness Month. September is PCOS Awareness Month. And we do have a slew of activities this month where we are creating a teal movement. That is what I call it, because the color for PCOS is teal, and I think it is also for cervical cancer. Yes,
it sure is.
So I'm creating a teal movement this month to engage women in our community who have PCOS, who may have it and it's undiagnosed, and just being able to go out there and show them that there's nothing to be ashamed of, and this can be treated, it can be reversed. It's something that we can get over. And so I just want to highlight, if I have time, some of the activities that we have coming up. So we have a t-shirt drive, because we want to do a Paint the Town teal on the last Friday in September. So we do have a t-shirt drive coming up. We do have other merch as well. We have pins, tumblers, we have some nice mugs as well that will be on sale. On the 28th of September, we have our Wellness Day coming up. It's a partnership with WINBVI. Like Dr. Scott said, getting your body moving is very important. And so for women with PCOS, even though we can't run around the track, we can do light workouts. And so hiking, doing some yoga, that helps women with PCOS. So that will be on the 28th. On this Friday, on the 20th, we have a meet and greet, which is where we will launch all of our merch. So you guys can come out and purchase, and you can meet, we can have conversations, bring all your questions that you have. I'll try my best to answer as many as I can. And if not, I'll point you in the right direction for answers to that. So I just want to encourage women. You're not alone. I'm here. I can be reached on social media by Armoy James, or you can contact the WINBVI organization, and they will surely get the message to me.
All right. Thank you so much, Queen Armoy. And then our final panelist, Dr. Nosa.
Thank you very much. I will just end by saying that PCOS, I said before, is a treatable condition. You treat according to what the patient wants or what the clients want. You could get pregnant, you could have children with it, the symptoms can be manageable. Good. Cervical cancer, 3 points. If you don't want to be vaccinated, the vaccine for those who want it can be taken from the age of 9, as early as 9, before they are sexually active, to the age of 45. 9 to 45, you can take the vaccine. If you don't want vaccination, you could do the HPV testing. All those are ways to prevent cervical cancer. It is a preventable cancer. I said it's one of the only gynecological cancers that can be prevented. If you don't want to do the vaccine, you don't want to do the HPV testing, you could do the pap smear. Pap smear can be done from the age of 25 and you stop at 65. Good.
Thank you, Dr. Nosa. Thank you so
You're
much
welcome.
for valuable contributions this evening. Again, this was facilitated by the WIN organization, WIN British Virgin Islands, Women in Need, serving women in need, providing reform projects and programs for women in need, taking care of single mothers who have needs, the health and well-being, the emotional well-being of women. I am so proud of this organization, not just serving in the British Virgin Islands, but across the globe, a global movement. I'm also very happy that Dr. Scott has been able to join us from Guyana. Team BVI, you guys know I absolutely love you. I want to thank Alicia Green for being a champion for women and for all that she does with the WINBVI organization. And again, remind you guys that, you know, our health is our priority. We need to be able to prioritize our health, especially as Caribbean women. Guys, I want to say thank you so much for joining us. My name is Jovan Wilson, mass media specialist. And as promised early in the conversation, we will certainly be back. But for now, take care and bye-bye.